Welcome to the 20-Minute Clinic. My name's Robert Westgate. It's my pleasure to be hosting this afternoon session. And with me in the room, we've got our special guest, Dr. Dominic Arnold. And as ever, we've got our trusty Paul Day, who's going to keep an eye on all the tech and make sure we stay on track.
I will indeed.
So welcome, Don. Would you like to introduce yourself?
Yeah, thanks very much for having me. It's a pleasure to be here. I'm Dominic Arnold, GP down in Penrith and also Clinical Director of Eden PCN.
So what should we talk about this next 20 minutes or so? I was thinking, would you be able to give a bit of background into how you've come to be a GP in Penrith and how you've developed into the role of Primary Care Network Clinical Director?
Yeah, of course. I'm slightly meandering route, I suppose. Medicine was my second degree. Did history initially, actually. Was a care worker of adults and learning degrees for a bit, was an accountant for a bit, and then graduate entry medicine at Swansea.
So a lot of hats before medicine even began.
Yeah, I had no kind of family or in healthcare at all growing up. And very fortunately, no one had a lot of interaction with the health service either. So it never crossed my mind really to work in as a healthcare professional. And then my gran, when I was at my first degree of history, got pancreatic cancer. So it was a very poor prognosis. And seeing her go through that, I then tweaked the mind actually with this something I want to do, care worker for a bit, then an accountant, and then the graduate entry medicine at Swansea, which is a 4-year course. Not too dissimilar from Cumbria in many ways, smallish city like Carlisle, Swansea, slightly bigger, but rural, quite spread out populations, often has, not necessarily the most equal access to services compared to other parts of the country. And then moved up here, got married, really wanted to move up near the mountains, love fell running, love cycling, love climbing. So came up here for my foundation year. So once I qualified, came up here.
That's a good plug for Cumbria right there, to say as to some of the reasons why you might have stayed as well.
Yeah, and it's I really enjoyed my 2 years in the hospital. Small, what would be called an old type DGH, but therefore you get quite a varied experience as a foundation doctor. And then straight onto the training scheme. I mean, because I did medicine as a second degree, I was always slightly older. So you're more likely to go straight into a training scheme rather than spending a few years doing different things. So straight into GP training for 3 years, qualified. And then relatively soon, I think I've been clinical director for nearly a year and a half. But the post came up within Eden. And because it's a difficult role, working across 10 different practices in Eden. And I had some input anyway into the PCN, partly because of the accountancy background, so some financial experience, and then put my hat into the ring. And April the 1st last year, became clinical director.
And how do you find the role and how do you balance the demands of being a clinical director with being a GP?
Yeah, I think it's a challenge, as you'll know, Robert. I mean, particularly within Eden. For those who don't know, it's a very large geographical area. I think it might be the biggest geography of any PCN in the country. 10 practices going from 800 patients up to nearly 16,000. Some dispensing practices, some non-dispensing. So it is difficult both in terms of working across North Cumbria, various meetings, but also trying to make sure you're engaged with all the different practices, working out what their needs are, what their population needs are, and then balancing that along with the PCN contract, what you've got to deliver, and the evolving kind of face and nature of the NHS and primary care in general. So it can be a challenge at times, and I guess it's trying to do what you can do with one's capability.
Would you say that your perspective on primary care has changed having gone into that leadership role?
I think so. I think you're more aware of how the jigsaw that is the system kind of fits together. And I know before I went into medicine, you see the NHS as very much one thing, don't you? Which is very understandable. When I speak to patients, they see it as one thing because
it's very much the public's thing, isn't it? It's just one big house.
We all do work for the NHS and to deliver services for the NHS. But obviously how that all fits together, how services are commissioned, how they function, how that varies depending on location, rurality, deprivation, that's hugely complex. And understanding more how decisions are made and how to influence decisions and trying to grow the voice of primary care, perspective has definitely changed, yeah.
And what have you enjoyed most about the primary care network leadership role so far?
I think it sounds corny, doesn't it, but trying to make a difference, both in terms of engaging the practice as much as possible, because it's easy if you're a smallish practice, it can feel, the PCN itself can feel quite a disparate thing, let alone North Cumbria, let alone the NHS or the ICB more generally. So getting to know the different practices, going to see them in person, speaking to the GPs, the wider team, the management team. Really enjoyed that. Trying to think holistically in terms of what does good primary care look like. And I guess the jury's still like exactly what that does look like. And it looks like different things in different places. One of the challenges needed. Mm-hmm. So the service that are available and needing the population, needing say in Penrith, will be different to Alston, different to T-Bay. So trying to juggle that and trying to find an answer that serves everyone and can promote the health and well-being of everyone whilst taking into account all of that. Been a challenge, but also, been enjoyable.
What would you say is your greatest success in the role that you're really proud of to date?
Greatest success. Yeah, I mean, that's always a hard one, isn't it? I'd say we make decisions or we engage with different practices that make up the PCN all the time and then collaborate also on a North Cumbria basis. I'd say greatest success has probably been practice engagement. Mm-hmm. Even in this now digital world, relationships and relationship building is so important. And we know that as a GP, that relationship with our patients is key. That's why they will trust us. That's why they will go advice or come back when we say that's when you need to come back. And we know that that's why continuity care is so important. And I'm always struck by that, how important relationships almost continue to be, despite how digital the world is. And so I think going to practices, getting that level of trust. So therefore, when you're making decisions or trying to propose suggestions that may not necessarily affect all practices in the same way, which is difficult, having that trust that therefore people are happy because they know in the long run where you're coming from. You're trying to promote primary care and the health and well-being of the population in general, and they trust you in that. So we've tried to move the meetings around, not from just Penrith, to try and make it evident that we're recognising Eden isn't just Penrith, just mm-hmm. like North Cumbria isn't just Carlisle, just like North East North Cumbria isn't just Newcastle. Mm-hmm. And I think that's really important. That hopefully, I'd like to think I'm trusted by the other practices. You have to ask them, obviously, to double check that. But I've had positive feedback from the different practices, and that's been really rewarding, actually.
So something about being inclusive, being very much focused on building relationships across colleagues, across practices, across the network, and across North Cumbria as well. Yeah,
because I think it's only through that therefore we can both understand the impact of decisions, but make the right decisions, but also be trusted in the decisions we make. And if any change is going to happen, we need to change management is a complex thing, isn't it? And bringing mm-hmm. people with us is complex as well. And I think that fundamental that is trust and relationship building.
So with you both being GPs, is that one of the most important things with patients then, sort of that building trust over the years if you've had longer term patients?
I think you can't underestimate the importance of that cradle to grave principle. Not only is it, I'm going to say, I hate the word nice, but not only is it a nice thing to do, as in, you're my doctor, you looked after my mum, you looked after my children, etc., etc. There's a really strong evidence base that continuity of care makes a difference. It allows better utilisation of NHS resources, it reduces all-cause mortality, it improves patient experience, it improves clinician experience. So that continuity of care, that relationship building between the clinician and the patient is really important. And there's parallels there across working with colleagues, working across practices, working across our health system. Whilst recognising the constraints in all of that, we can't always do what we would want to do. Those relationships are absolutely essential for making the best of what we've got and for working through what can be sometimes very challenging decisions.
And I echo that. Robert says that the evidence base for continuity care is so strong. If it was a drug, we'd all be taking it.
We'd be prescribing it by the bucket.
It's that good.
Yep.
And I'm always struck by somebody who hardly comes in to see us, and they might have seen one of us 3 years ago, and they'll ask, can they see that one person? Even though they've only seen the one person ago. To make even that level of continuity, and you can think about that as a patient, even if you haven't been, it's nice to see someone that you know, that impact or that interaction you have with a healthcare professional. It's often so important. It's so important for you, isn't it? It makes such an impression. And I guess that's one of the challenges of what we do in primary care, particularly now, in terms of we talk about access, we talk about bringing access to GP in multiple different ways, enabling that whilst also promoting continuity and enabling patients to understand. A lot of patients want that, patients to understand the benefit of it as well.
That's right. And there's been a lot of focus, for as long as I can remember, on the importance of continuity of care. The evidence base for it just gets stronger and stronger. And it starts to weave into policy. I mean, it's in Fuller Stocktake report, for
Yeah,
example.
yeah.
You know, how do we enable continuity of care in a really constrained health system? The real tensions in that, I think, as well, because you can turn continuity of care almost into something that needs to be done to or measured
Yeah.
or
Yeah,
a
yeah.
metric. And if you haven't got the tools, the resources on the ground to actually just deliver continuity of care, the rest of it becomes a bit nonsensical. But that there's a risk of turning it into purely a metric without recognising that some of the root issues around improved continuity of care just rest with the right sort of balance, proportion of workforce in primary care and all the sort of policy and funding and structure that goes around that.
Which I suppose is frustrating when you've got cutbacks and all these other challenges, shall we say, to use the positive.
Yeah, and you can only continuity care is possible with the right resourcing.
Mm-hmm.
Is the thing. Otherwise, it becomes harder and harder to deliver.
And I sometimes view a lot of what we do in general practice as a mix of sort of transactional stuff. There's someone who's maybe ordinarily well, they have an episode of ill health and they have some continuity through that episode, job done, move on, etc. And then people with long-term conditions who have regular contact with the surgery, with general practice over a much longer period. And trying to balance both transactional and relational care with very limited resources on the ground becomes really, really challenging. That's part of the conundrum of how we currently, I think, deliver general practice. I think models look slightly different in different places depending on what the mix is. But trying to maximise continuity whilst maintaining access for people that need it at the right time, right place, etc., etc. Really difficult conundrum. Can't underestimate how challenging that all is. I was going to come back to you, Dom. So, what does a typical day look like for you as a GP and as a clinical leader? And what's the proportion of the two? And when someone might say, "I can't see my GP," he's always off at these meetings and things. I get accusations like that.
He's on that podcast again. Yeah.
I know you work hard, and I know you serve the people of Penrith really, really well. But what does a day look like, and how do you justify the investment of time in the different things that you do, including patient contact, for the greater good of general practice?
Yeah, I think days are varied. I mean, I still do 2.5 days of clinical, so they're long days. So get in the practice about 8, leave about 7, 2 long days. Everyone's a half day. That is clinical, seeing patients, speaking to patients, doing the admin around that. And I think that is really important, both so you're aware of the current pressures of the system, and therefore I think only through that can you work on solutions to try and help it. But also because I enjoy it. I'm still struck by people you've never met will come in and tell you really deep, profound things about themselves, and that's continually humbling. So that is the clinical side, and then I spend about 1.5 to 2 days a week, depending on the week, on various meetings, emails, working on projects with the PCN, working on stuff within North Cumbria. And those meetings can be anywhere. They can be virtual, in person. Also try and network with other similar PCNs, because obviously my PCN is very rural, about 60,000, as I said, 6,000 people. So I've been over to Alnwick to see their PCN, went to their away day, just to try and network, get ideas, because we're all doing different things, and through idea sharing and again building this networks, not even just within your PCN, not just within the place that is North Cumbria, but wider afield, that we can really work out what is the best for our population and continually improve. This morning, for example, I'm discussing with one of the PCNs, another PCN in Northumberland, and I've reached out to PCNs down in South Cumbria as well. So that is a lot of it. It's trying to, it's not technically in one's contract. Does that make sense? It's not. There's not a list. This is what you should be doing. But in terms of trying to make the PCN work for the people of Eden, which is what it's there to do, as well as possible, I see that as core to my role, really.
And I think you're right. It's so important to be grounded in the reality of general practice as a general practice leader, isn't it? To be able to, firstly enjoy being a clinician and put in that service, but also be acutely aware of what's happening on the ground, what challenges are facing yourself, challenges are facing patients, the surgery, and colleagues. Yeah, it's just so important to have that reality that I suspect generates a credibility for the role as well, and an authenticity in what you do.
Yeah, no, I agree. And I think sometimes when decisions are made centrally, you're never quite sure, and that's partly because you're never sure who's made the decision, how much that decision has been informed by what it's like on the ground. Does that make sense? And that's why whenever I'm trying to make sure I'm informed, but not And it's important, therefore, not just to be blinkered by one's own experience. That's why it's important to reach out to the other practices, speak to other PCN clinical directors to try and work out what is happening elsewhere on the ground, sometimes what can help, what are the pressures. But you're right, I don't think you can put a metric on the importance of that on the ground knowledge.
I'm clearly in general practice at the minute. We're at a fairly turbulent time in terms of the cusp of a new national contract, which is long overdue. We've come through austerity. We're potentially looking at future austerity, a new 10-year NHS plan, etc. What's your sort of hopes and ambitions for general practice for the next few years, would you say?
Good question. I think primary care, and that's why fundamentally I'm a GP, I think has such huge power, such huge capability and opportunity within primary care to improve health outcomes, to reduce health inequality, to enable people to get on with their day-to-day lives, because that's what they want to do. That's essentially why they come and see you. But also do that in a cost-effective, local way. We know that across the world, healthcare systems are getting more and more expensive. And particularly when things end up in secondary care, those costs can increase. And that isn't just a thing that's happening in the UK, that's happening across Western Europe, America, or developed healthcare systems. And I really do fundamentally believe primary care can be an answer to that. It can be that holistic wraparound care that people need when they fall ill, or maintaining their health if they've got chronic conditions. And for that, need resources. And I think that resource will pay dividends, as I said, in a plethora of ways in terms of people's health, people's satisfaction with the NHS, efficiency, the ability of the rest of the system to function. Because 90% of patient interactions happen in primary care. And for those to work well and to enable the other 10% to work well, primary care needs effectively resourced, for the well-being and health of the nation, really.
In terms of looking forward and hopes and ambitions, what would ideal general practice look like for you in a few years' time?
Amit will be proud of that question, Robert, because he asks everyone that once. So if you're following the podcast, listeners, you know that's Amit's favourite question as well.
So I think it's, ideal general practice. So I think... I'm trying to think. That's a good question. I'd say the ability to promote continuity of care and the understanding from population and from decision makers of the importance of that without a arbitrary metric that puts on that, therefore to judge you on it. But I think that is what I think ideal that promotes that and has the resources to enable that. We know currently people's satisfaction with the NHS and primary care currently, I think, is an all-time low. Trying to reverse that trend. And that's a really difficult thing, isn't it? And I think hopefully a 10-year plan, I mean, they've talked about hospital to community, haven't they? Been central to that treatment to prevention, which primary care is ideally situated to be. So enabling us to do that, hopefully will come out on it. So I think, continuity of care, promoting health and preventing ill health, but remaining rooted in our communities. Because it's the practices that they know their communities, often better than edicts from centrally that may be designed for a slightly different population than what yours is. So I think the flexibility to serve them, I think related to that is probably fewer targets. I mean, the benefit of KPIs is well debated within healthcare systems, whether they make much difference or not. And one can understand why people that hold the purse strings in terms of transparency, like these KPIs and these targets, but the evidence is they don't really affect health outcomes on most of them, or morbidity or mortality. And I think therefore trust centrally to practices to do the right things for the population, I think, is also key.
So I guess in summary, it's a health service that enables general practice to put into place properly resourced continuity of care and reap the known benefits, the known evidence-based benefits of that. Yeah,
that's exactly right. And I do truly believe that it could be transformative for the NHS and the health of people up and down the country. It takes a lot of faith, and there's a lot of difficult discussions in terms of if there are any resources moving from secondary to primary care. But I think the evidence base from here and around the world would show it's a no-brainer.
Well, in my usual GP form, I think I've slightly run over time for the appointment, and our 20-minute clinic, I think, is about over. So I'm just going to wrap up and say thank you ever so much, Paul, for keeping us on track.
That's okay.
And
always a pleasure.
And Dr. Dominic Arnold, Thank you very much.
Been a pleasure. Thanks very much.